hear and see me clearly. Um, and I'm going to talk to you today on how to manage common thyroid problems. And hopefully, this is relevant for your practice, but also for your exams as well. So, what I hope to cover is looking at the anatomy of the thyroid gland, just to remind you. And then we think of three very common thyroid conditions. So, an underactive thyroid, overactive thyroid, or nodular thyroid disease. And just to remind you, and I'm sure you're aware of this, the thyroid gland sits in the middle of the neck, but there's some very important structures nearby. So you have the trachea, which is behind the thyroid gland, and the thyroid gland's in a butterfly shape with the left lobe, the right lobe, and also the isthmus in the middle. And just as a reference, the adult weight of the thyroid gland is roughly around 20 grams. And each lobe, when you ever do a ultrasound of the thyroid gland, you may get a report saying the thyroid size is normal, but you may have always wondered what's the normal radiological scan report. Well, each lobe should be roughly around about 4 by 2.5 centimeters, but we do commonly see the right lobe to be larger than the left lobe, and that's a normal variation. So behind the thyroid gland, as you remember, are the parathyroid glands, and these glands are very important because they secrete the hormone parathyroid hormone that's involved in calcium balance. And why it's very important is that some thyroid conditions require an operation by the thyroid surgeon, and the thyroid surgeon has always got to be careful of various structures nearby, so the trachea being one of them, but also really important is the recurrent laryngeal nerve, because if these are severed during the operation, then your patient will need a tracheostomy. Um, so a very delicate operation if patients do need their thyroid gland removed. And if the thyroid gland is removed, the histopathologist can look under the microscope and they typically see thyroid follicular cells. Now, this is important because in some patients they may have thyroid cancer where these thyroid follicular cells aren't as smooth as this, and there could be signs of thyroid cancer. So histopathology very important if you're thinking of malignancy in a patient. But if you remember from a biochemical point of view, there is the hypothalamic-pituitary-thyroid axis, which keeps the thyroid balance in the body at the optimal level. And the thyroid gland produces the hormone thyroxine. A bit of it gets converted outside of the thyroid gland at the level of the tissue into T3. But this is regulated by that hormone TSH, which is produced by the pituitary gland. And all the way from the hypothalamus, the TSH is regulated by thyrotrophin releasing hormone. And these hormones are all in balance. So if there ever was a lack of thyroxine, the pituitary senses it and the TSH level goes up. But if the pituitary gland didn't produce enough TSH, then the thyroid hormone would be low as well. So it's the self-regulating axis. And normally this axis is in balance, but about 5% of the population may get some form of thyroid disease. And that can be either overactive, underactive, or nodular thyroid disease. We do know it's more common in female patients rather than in male patients. We don't fully understand why that is. One thought could be an estrogen effect, but it hasn't really been shown in studies. But certainly, and I'm sure you have a lot of patients with thyroid disease, they tend to have a very strong family history, and it tends to be the female members of the family that are affected. And the ratio of overactive to underactive is 1 to 1. Now, primary hypothyroidism, you will deal with a loss in the if you are general practitioners or family practitioners, and patients typically present with symptoms of feeling tired, lethargic. But primary hypothyroidism, the most common cause is an autoimmune cause or Hashimoto's. There can be some other causes you do need to bear in mind. So some patients, if they have an overactive thyroid, are treated with a treatment called radioiodine therapy or even thyroid surgery, and that can lead to hypothyroidism. So patients do need to be on thyroxine after that. If your patient has been brought up in a part of the world that has iodine deficiency, then that can also cause thyroid imbalance. And then medications commonly cause thyroid disruption. So I have many patients who are under the psychiatrist treated with lithium who have thyroid dysfunction, or even the cardiologist who treats atrial fibrillation with amiodarone can end up with a underactive thyroid. But this is always important. Bear in mind your patient may have transient hypothyroidism, and that's a thyroiditis. And we'll focus a little bit more on that in future slides, later slides. But just bear in mind that if you commit someone to thyroxine, it may not be a permanent thing if they do have thyroiditis, because the thyroid may recover after a couple of months. But typically, patients will present with all of these symptoms. And if you look at the list, many patients in the public will be complaining of these symptoms, certainly weight gain and tiredness, but not all of those patients will have thyroid disease. So if you do see a patient with these symptoms, I'm sure you would request thyroid function tests. And if you do pick up hypothyroidism, then you can save your patient from getting worsening symptoms. Because in the olden days, a lot of patients presented to hospital very unwell with myxoedema coma before thyroid function tests were more routine. But there can still be cases of patients presenting with myxoedema even in Western, departments. So this is actually a case reported a couple of years ago in the New England Journal of Medicine in America, where you would hope they would be doing their thyroid function test quite readily. And you can see this patient typically presented with features of hypothyroidism. So classical facial features, losing of the hair, unkempt, and also dryness of the skin. And this patient presented with hypothermia in hospital. I mean, you can read the case, but it's very interesting to see patients can still present with myxoedema coma even in the current climate. But this patient was given levothyroxine, and you can see a dramatic change later on in the year in the appearance of the foot in terms of the facial appearance. And that one tablet of levothyroxine has transformed this patient's life. Now, thankfully, because we do commonly do thyroid function tests if patients complain of tiredness and weakness or weight gain, but there will still be occasional patients that are missed, and we really need to save them from coming into hospital like this. So in primary care, you probably do a lot of TSH blood tests, and that will pick up the vast majority of patients with thyroid problems, and it should pick up all patients with primary hypothyroidism. If your laboratory offers you a T4 level, it's always good to do, because some patients who complain of those symptoms may have secondary hypothyroidism. And remember, in secondary hypothyroidism, the TSH level can still be normal with a low thyroxine level. Think about doing those thyroid antibodies, because patients can be at risk of autoimmune thyroid disease being the most common cause of hypothyroidism, i.e. Hashimoto's syndrome. But think of other biochemical changes that can happen. Hypothyroidism can lead to normochromic macrocytic anemia. So hemoglobin and MCV is an important test to do. Occasionally, if it's very severe, like myxoedema coma, patients may present with hyponatremia. Bear in mind, if you ever do measure a prolactin level and it's raised, always make sure you've measured thyroid function tests, because hypothyroidism can increase prolactin levels. And then various muscle markers can change, such as creatine kinase, liver markers, AST, and LDH levels in primary hypothyroidism. But at the very least, I would be saying you should do a TSH level, try to do a T4 if you can, and thyroid antibodies. But always look for other autoimmune associated illnesses. So you may have patients who are diagnosed with hypothyroidism, primary hypothyroidism, who then are treated with levothyroxine, and they still don't feel well. They still feel tired, lethargic. Or some of these patients may have other autoimmune associated illnesses like B12 deficiency, celiac disease. And I don't think we commonly test for that when we should really, because patients with any autoimmune condition can be at risk of other autoimmune diseases. And it's not always thyroid that could be the cause of the tiredness in your patient. In terms of treatment, well, levothyroxine is a conventional way to replace the thyroid. It's normally weight dependent, so most of our patients are on about 100 to 125 micrograms of levothyroxine if the thyroid is completely not working. But there's a whole spectrum of patients who may have autoimmune hypothyroidism, who may first start off at 50 and then build up to 75. I occasionally have patients who are over 200 kilograms who may be on up to 250 or 300 micrograms of levothyroxine a day. But bear in mind, if your patient's requirement for thyroxine suddenly increases, they may not be fully compliant with their medications. So always, I'm sure you do go back into the history and make sure they're taking their levothyroxine. Very occasionally, we ask them to come to clinic to have a supervised taking of levothyroxine, so we can measure thyroid function tests after that to see are they really taking their medications. Because if they're coming up to clinic regularly and being watched to take thyroxine and their thyroid levels get back to normal, then really it's a compliance issue. Just be careful in your patients who are elderly, because they may be at high risk of ischemic heart disease. And if you give someone too much levothyroxine, they can be at risk of a cardiac event. And normally, as you know, thyroid tests take a while to readjust. So we ask patients to have a repeat thyroid function test in at least 6 to 8 weeks. Once they're on a stable dose, at least once a year, I would say. And always remind patients you have to take thyroxine on an empty stomach, have nothing to eat for at least half an hour after taking levothyroxine, and ideally no caffeine products. And if they're on supplements, so some patients may be on iron replacement or calcium replacement, that can interfere with the absorption of thyroxine, or vice versa. Thyroxine may interfere with the absorption of calcium or iron. So I always ask patients to take the supplements at least 4 hours after the levothyroxine. One way to do that is they take levothyroxine first thing in the morning. They take their vitamin supplements at lunchtime or even in the evening. So you may have some patients whose thyroid function tests still aren't well controlled, and just think about interaction of supplements to the thyroxine. But T3, liathionin, can also be given for thyroid replacement, but it's not a conventional way to replace the thyroid. All the big bodies in the world, thyroid bodies, the American, the European, and the UK thyroid associations, carry on saying that we should not really give liathionin or T3, which is shorter acting thyroid replacement, and it should ideally be levothyroxine. And part of the reason is that there's no real clinical evidence that T3 is better than levothyroxine. And the other thing to note is if you have such a patient on T3, there can be very big swings from high to low on T3 because T3 has such a short half-life, whereas levothyroxine is a bit longer acting preparation and it tends to be more stable. But there will always be some patients who swear by they feel better or would like to try liothyronine. And I suppose from a clinical point of view, you just need to remind them there's no real clinical evidence that T3 is better than T4. If it is to be offered, it should really be offered by a specialised thyroid clinician. But you know, we always do say to patients there's no real good randomized control studies to say T3 is better than T4. The only other time to be careful about thyroid hormone levels are during pregnancy. And there is a lot of debate amongst gynecologists and endocrinologists in terms of the actual TSH level we should be looking at in conception and throughout pregnancy. The consensus is if someone does have primary hypothyroidism, we should be aiming for a TSH that's more nearer 2.5, which is different to if your patient isn't planning on getting pregnant. And you should remind your patients levothyroxine replacement is safe in pregnancy. We need to make sure that thyroid function tests are well monitored, because if not, there is always a risk of miscarriage or fetal problems or maternal complications if the thyroid isn't well controlled. There's two ways to think about changing doses of levothyroxine in pregnancy. Some people advocate in the first trimester to increase the levothyroxine dose by 30 to 50%. Others like to monitor the thyroid function test in the first trimester every 4 to 6 weeks and adjust thyroxine dependent on the thyroid function test. But as a general rule, the dose of levothyroxine does increase in pregnancy. So if patients are on 50 micrograms, they typically end up being on 75 throughout pregnancy. But after pregnancy, we always ask patients to go back to their pre-pregnancy dose. And that's important because if we don't, then they may become over-replaced after pregnancy. Now, this is a more tricky situation, something called subclinical hypothyroidism. And in some patients, it may not entirely be subclinical because they have clinical symptoms. From a biochemical definition, this is where patients have a thyroxine level which is in the correct range, but the TSH level is elevated. Some studies have suggested that these patients may be at risk of getting clinically apparent hypothyroidism. There is some evidence that this could be a risking patients developing coronary heart disease. But what really muddies the water is that there's no real study showing that if the TSH is between 4.5 and 10, and your patient has no symptoms, giving them levothyroxine will reduce health outcomes in the long term. So this is always a very tricky scenario if your patient has no symptoms. If they have clinical apparent hypothyroidism and the TSH is between 4.5 and 10, then we should offer patients a trial of levothyroxine to see if that improves any of their symptoms. And certainly if the T4 is low with an elevated TSH, then we should replace the thyroid levels. But you will have these patients who may have a slightly raised TSH level, normal T4, have no symptoms, and then you and them will be wondering, do you need to treat them on levothyroxine? I tend to monitor these patients, have a repeat thyroid test in 3 to 6 months' time to see if there's any change and what the trend is. The other cohort of individuals you should be aware of is the elderly cohort, because naturally TSH levels go up with age. So the reference range for TSH in an elderly patient may be up to 5 or 6 milli-international units per litre. So I suppose that it's really looking at your patients and seeing, do they have those symptoms of hypothyroidism? Will starting the levothyroxine make any change in those symptoms? If you give your patient a trial of levothyroxine and there's no real change in their symptoms, then their symptoms aren't really related to hypothyroidism. So that's everything about an underactive thyroid. We can now move on to hyperthyroidism. And one way of looking at this is looking at high uptake scenarios or low uptake. So Graves' disease is the most common cause of a overactive thyroid level, and these patients have positive TSH receptor antibodies. You can get patients with a multinodular goitre that becomes overactive, or even a single adenoma. These things are very rare. TSH induced, meaning a pituitary adenoma causing hypothyroidism. Some of our patients with thyroid cancer, we like the TSH to be low to prevent any tumour cells from reoccurring. So we tend to give them a little bit higher dose of levothyroxine. And these are very rare things. So a germ cell tumour producing more TSH levels, thus causing more thyroxine. And low uptake is important because these are all your thyroiditis conditions, postpartum thyroiditis or subacute thyroiditis. And these normally are temporary things that get better. Amiodarone thyroiditis can occur, unfortunately, with amiodarone, and you have two options there, either stopping amiodarone, but remember amiodarone has such a long half-life, or potentially replacing the low thyroxine level with levothyroxine. But the clinical features of hyperthyroidism are the reverse to hypothyroidism. So patients' appetite increases, they have weight loss, which isn't good weight loss. They can get palpitations, tachycardia, diarrheal symptoms, feeling anxious or tremulous. They can also get eye symptoms as well. And Graves' disease, as I said, is the most common cause of an overactive thyroid. And these patients develop TSH receptor antibodies to the thyroid gland, but also the eyes as well. And it's important to remember that the eye antibodies may be there many years down the line, even if you do treat the thyroid. And these patients can also get problems with the skin in terms of pretibial myxoedema. And occasionally we see patients with severe eye disease that turns out to be Graves' eye disease, and then you find out they have an overactive thyroid. So these are quite challenging patients to treat. The ophthalmologists are very involved in these cases. They may give them steroid therapy such as prednisolone. Sometimes immunosuppressive agents may be used as well. And this is the pretibial myxoedema that patients may get. Now, the other side of the coin is if patients have a multinodular goitre. This isn't autoimmune, so these patients won't be at risk of pretibial myxoedema or changes in the eyes, which are driven by those TSH receptor antibodies. But the benign adenoma in the goitre is producing more of the thyroid hormone. So these patients still get the same symptoms such as tachycardia, tremor, weight loss, palpitations, but not the eye signs. And if you ever suspect someone with hypothyroidism, you do the TSH, it's low, T4, T3 levels will be high, and then if the thyroid is smoother, you send off TSH receptor antibodies, which are positive in Graves' disease. But again, as I mentioned for hypothyroidism, you should always look for other autoimmune associated diseases with hyperthyroidism as well, like B12 deficiency, celiac disease, very rarely Addison's disease as well. So really, really important to do. Now, this is the radionucleotide scan of someone who has Graves' disease. They have very uniform uptake in the thyroid. If you've got someone with a toxic multinodular goitre, you can see positive uptake throughout the whole thyroid. If you've got someone with just an autonomous nodule, only one part of the thyroid is lit up, and then you have suppression of the rest. And this is similar in someone with a very small hot nodule. So the technetium scan can help if you're still not entirely sure is this Graves' disease or if this is a nodular goiter. In terms of treatment, we've always in the UK given medical therapy, so carbimazole or propylthiouracil and a beta blocker for 18 months. In the US, their system is more insurance based, so they normally give radioiodine therapy first line, and the thyroid stops producing thyroxine, and they go on to levothyroxine for the rest of their life. In the UK, we're sort of moving towards that. So there is a view that patients should be offered radioiodine first line. There's still a bit of controversy over that, because some people feel that by giving anti-thyroid medications, there's still a 50-50% chance after 18 months that your patient may not need any more definitive therapy longer term. So you'll still have patients whose thyroid is preserved, they don't need any further treatment, whereas there are then still a proportion of patients who will need further treatment like radioiodine or surgery. But one thing to remember is in your Graves patients, always look out for the eye symptoms, which can occur many years down the line. And these patients may be at risk of problems with the eyes that can develop many years down the line after the thyroid is still treated. So if you've got a patient who's had treated Graves' disease 20 years ago, but comes with you with gritty eyes, diplopia, that patient needs an urgent ophthalmology assessment just to see if they've now developed Graves' eye disease. Normally, the Graves' eye disease tends to occur at the time they've been diagnosed with hyperthyroidism, but very rarely it can occur many years down the line. Then thyroiditis is the other important thing to think about in someone with an overactive thyroid. Particularly around the winter months, you get patients who complain of such severe sore throat and then suddenly start losing weight for no reason. They may have a temperature, they may have a raised ESR level. If you do a radionucleotide scan, these patients will have no thyroid uptake whatsoever in the thyroid region. And this graph is quite important looking at the time course, and I do show it to patients so they understand what may be occurring in the thyroid gland. So what tends to happen is at the very beginning, the thyroid levels are fine. So the blue line is thyroxine, the purple is TSH levels. And then suddenly you get this inflamed thyroid and a lot of the thyroxine goes up. So the blue line goes up and the TSH hormone levels go down. And then the thyroid suddenly becomes depleted of thyroxine. So what happens then? The thyroxine levels sharply comes down and the TSH levels go up. And then hopefully the thyroid will recover, produce more thyroxine, and then it goes back to baseline. But it doesn't happen in everyone. That some patients may permanently stay underactive, so the blue line permanently stays down, and these patients may need to have thyroxine for the rest of their life. Now, in terms of how long this takes, the time course, it can be, between 3 and 6 months, so a long period of time. And this is a similar pattern with postpartum thyroiditis as well. Invariably, most postpartum thyroiditis will stay hypothyroid, but some patients it can recover. But this is triggered by viral infection. We don't know why some viral infections trigger the thyroid in some patients and not in everyone. But if the patient has a strong family history of thyroid disease or thyroid antibodies, it can make them a bit more predisposed to the condition. In terms of treatment, these patients have, very sore throats, so non-steroidals are important. Steroid medications, prednisolone, can calm down the thyroid, and beta blockers are good to prevent that tachycardia from occurring. Thyroxine may be necessary in some patients, particularly if it's more permanent, which can occur in about 10% of patients. So we talked about underactive thyroid, we talked about overactive thyroid. In the final part, we're going to talk about nodular thyroid. And this is probably the most common and difficult part of thyroid medicine, because patients tend to have ultrasounds nowadays for many reasons, and you may find an incidental thyroid nodule. If it's very large, patients will feel it, or you will feel it, but most of these are picked up incidentally. More common in female patients rather than in male patients, more common in the elderly. And we do know in patients who are in low iodine uptake areas where their food isn't fortified with iodide, they may be at risk of thyroid nodules. But maybe if I throw a question to the audience to make it a bit more interactive, if I were to come to you right now and scan your thyroid, how many of us do you think would have thyroid nodules? If anyone would want to maybe come off mute and hazard a guess or write in the thing. Does anyone think it's 10%? 20%? 25% we've got from Chanel. Okay. Anyone agree or disagree? 15% we've got. Yeah. So actually, if I came around with my probe today, 10% Chandler. Okay, great. It's up to 50% of us may have thyroid nodules. And that's really important, not to alarm you in the audience, but this is what our patients will be facing as well. So it's very common to find thyroid nodules incidentally. Now, the vast majority of these nodules will be really, really small, millimeters, and not symptomatic. It's really the large nodules we'd be worried about. But I suppose with this knowledge, you may not want to do ultrasounds on everyone, because it may not offer you any further information. They've got 1 in 2 chance of having thyroid nodules. But most of these, as we're saying, some studies have suggested up to 65% are picked up on ultrasound. Very occasionally we can see it on patients, so probably about 47% of everyone with nodules, you can definitely see it. And sometimes they can be picked up on nuclear medicine scans or scans for other reasons like CT of the chest. But if these nodules are very large, they certainly can cause problems. So they could cause thyroid dysfunction, normally an underactive thyroid, but some of them can be toxic nodules, as we've seen before in the hyperthyroid section. If they're very large, they can cause compression and can cause problems with swallowing. Patients may be at risk of thyroid cancer in some of them. And I suppose this is why the ultrasound of the thyroid is very useful, particularly if you're making sure they don't have thyroid cancer. because our ultrasounds nowadays are very good at working out if patients may have thyroid cancer or not. Some of the history and examination can point towards it. So if your patient has a strong family history or history of neck irradiation or a history of Hodgkin's or non-Hodgkin's lymphoma, there may be at more risk of thyroid malignancy. If they're very young or very old, there could be. If they're male, there could be, or if they've got symptoms of compression. Certainly firm nodules we'll be very concerned about, and as well as nodules that have lymph node invasion or vocal cord paralysis. But hopefully in these patients you will all do an ultrasound of the thyroid, and that's because thyroid cancer is still very common in the community, and the rates have sort of been going up over the last 20 odd years. And part of the reason is that these patients will be having ultrasounds of the thyroid for other reasons, and you incidentally pick them up as thyroid problems. But there's a whole host of tests you can do, but only a limited amount of tests that really matter in clinical practice. So I suppose the clinical features are important. TSH, there is a view that if the TSH is suppressed, for example, hyperthyroidism, is less likely to see patients with thyroid cancer. Ultrasound is important, and the FNA, which we'll have a look in a second, is important to make sure that there's no hint of abnormal thyroid cells. But all of these other ones, like molecular markers, calcitonin, PETs, MRI, CT, aren't routinely done, or elastography. That's the stiffness of the nodule. Calcitonins we can very rarely do if you are thinking medullary thyroid cancer, this very rare type of thyroid cancer, but certainly isn't really used in clinical, routine clinical practice with nodules. So I would say it's really clinical features, ultrasound, plus or minus an FNA, and thyroid tests that you will be doing in the vast majority of your patients. Sometimes the nuclear medicine scan can help. Certainly if there's a cold nodule, there is a thought that the risks of malignancy will be higher than in a hot nodule. But there are classical features on an ultrasound, which is listed here, that could mean that patients are more at risk of thyroid malignancy. And the radiologist now can give a very good ultrasound characteristic, which is called a U ultrasound scoring system. And essentially a U1 means there's no thyroid nodule. A U2 is benign nodule that doesn't need any treatment or any investigations. But if your patient has a U3, U4, U5, then there's a higher risk of thyroid malignancy. And we tend to recommend FNAs in anything that's above a U2. So U3, U4, U5. Most U3s come back normal. U4, U5, more suspicious for thyroid malignancy. And once the patient has a FNA, there is a thigh score given by the cytopathologist, the histopathologist, that can let us know if the patient may have some abnormal cells. So a thigh 1 is non-diagnostic, and these are normally repeated again. A thigh 2 means it's benign cells. Sometimes if the nodule is a U3, U4, U5, we like 2 FNAs that show thigh 2 in 2 spaces of time. 3, 4, 5, more likely to be thyroid cancer. And these 3, 4, 5 are treated with thyroid surgery. So the surgeon can look under, the histopathologist can look under the microscope to make sure there's no thyroid cancer cells. And if there are thyroid cancer cells, the whole of the thyroid is removed, and then these patients will then have radioiodine therapy, which means that all the remaining thyroid cells are blasted. And then we tend to like them to, for a period of time, have TSH suppression to prevent any abnormal thyroid cells from occurring again. And these patients are followed up longer term with at least an annual thyroglobulin level. Thyroglobulin is a marker for thyroid cancer. If you've still got thyroid cells still in the body, in the thyroid gland, thyroglobulin will still go up. But after surgery and radioiodine, you would expect patients not to have any thyroid cells remaining. So if the thyroglobulin goes up, your patient may be at risk of reoccurrence. So, most patients with thyroid cancer, when they're treated successfully, have normal life expectancies. Some types of thyroid cancer, like anaplastic or medullary thyroid cancer, will have changes in life expectancy. The most common one is papillary. Occasionally, you can get follicular cells. But the survival rate's pretty good compared to other cancers. And certainly, as patients are diagnosed much earlier on, the survival rate is going up all the time. It's really the anaplastic ones that will dramatically change life expectancy. So that's a whiz through thyroid medicine. Hopefully, I've illustrated that 5% of the population will have some form of thyroid disease, be it overactive, underactive, or nodular thyroid. Thyroid problems are more common in females than in males. If you have a patient with primary hypothyroidism, then levothyroxine is the treatment option. If your patient has thyroiditis, remember, maybe just monitor that patient to see where the thyroid hormones levels are going. And thyroid nodules, more common than you may think, and the majority of them are totally benign. I'm just going to stop there because I'm conscious I've done a lot of talking, and happy to take any of your questions. Let's come out of that. Was that all okay? Do you see a lot of thyroid conditions in your practice? Yes, majority undiagnosed, yeah. Yeah. So hopefully, remember, as you would do if your patients have these symptoms of hypothyroidism, to routinely do those thyroid tests. I think one thing we always forget with the hypothyroidism or even hyperthyroidism is the other autoimmune associated illnesses. So certainly, looking out for that would be important. Great. So we've got a question here. This is from Dippo, if I'll read out to everyone, if you can't see it. How soon after pregnancy should the levothyroxine go back to pre-pregnancy levels? Do we reduce the dose also if they're also breastfeeding? Yes, so as soon as they deliver, you should go down. Breastfeeding shouldn't really change the thyroid levels. What tends to change the thyroid levels is the blood volume in pregnancy, and that will correct itself post-pregnancy. So I would just go straight down to the normal level. I've got a message from Zarbib. Will T3 and or T4 help with the diagnosis of hypothyroidism instead of T4? Well, normally the TSH would be the key marker because TSH will change if the T4 level or T3 level is low. There is research going on to reverse T3, it hasn't really been teased out, and you may get patients coming to you saying, I've got problems with thyroid conversion through enzyme problems. I suppose one thing to say to them is there's no real long-term evidence that that will cause hypothyroidism if your TSH level is still normal. So I think the TSH is the most important hormone to measure. Just as endocrinologists, we like to do the T4 level as well, because you may be missing some patients with this rare secondary hypothyroidism. But if the T4 or T3 level is low, then the TSH should go up. The other useful part of T4 and T3 is in a condition called sick euthyroid condition. So these are patients who come onto intensive care, and sometimes the T4, T3 level is low, but the TSH is still normal. They tend to correct itself once the patients recover from their other illness, because the thyroid switches off at the time patients are very unwell. Great. Any other questions at all? Great.